So Stefan, when we think about decision-making in a hospital for controlling costs, or we think about decision-making in an ASC for controlling costs, who determines cost control in a hospital? Who determines cost control in an ASC?
Good question. In the hospital, it's done by committee, and the hospital really tries to engage the physician of controlling cost. Because we got to be really careful when we talk about cost for the hospital and cost for healthcare. So if the total joint has a reimbursement of $50,000, that's $50,000 cost to healthcare. But if it costs the hospital to do it for $40,000, their margin is $10,000. But if they can go from $40,000 to $30,000 or $20,000, their margins goes up. So their profits improve, but the total cost of care doesn't go down. And it's a really important question. And so in the hospital, they do all kinds of different games with the physicians to try to engage them in reducing their cost. Because we as physicians profit financially nothing from reducing the cost for the hospital. Unless we're in an ACO, and like I'm in an ACO with our hospital, and every year we get together and they determine certain measures that we need to reach, and then if we reach those measures, which part of them are quality measures, part of them are cost measures, at the end of the year, they share some of that savings with us and then we get a check. So it's really made by committee. In an ASC, it's very different, right? Because I, as an owner in the ASC, the lower I bring the cost, the more margin as an owner I get. So there's a little bit of a conflict there. And so we really have to be careful as a surgeon in the ASC, we don't make decisions that are that favor our bottom line rather than improve patient care. So it's a really good question to ask, and it's very important to keep that, be ethical and do the right thing.
Mm-hmm. So with that, there's bad actors everywhere, right? And it doesn't mean that can't be a bad actor in a hospital setting, regardless of whether the surgeon does, A or B. But you have influences in every environment. In the ASC is the surgeon, owner, part owner, full owner, who knows. And then you've got private equity sometimes too, the investors. And capitalism's a beautiful thing until it's misused.
Correct.
And so it comes almost exclusively down to ethics.
It does.
Yeah.
And it's very important. And so, I always say to people, it's when you get up in the morning, you look in the mirror, you got to like the person that you're looking at. And unfortunately, healthcare has a tremendous potential for abuse on the ethical side because there's so much money in it when it comes to the device companies, when it comes to hospitals. And never a day that doesn't go by where I don't get an email from Becker's where there's a key 10 lawsuit filed for kickback and so forth. And so it really comes down to ethics.
Yeah, and with ASCs really exploding, whether it's ortho, uro, cardiology, how do we manage that moving forward, in your opinion? Because business is to make a profit.
This is to make a profit.
And
yeah.
where is it gray and where is it clearly black and white? And
right.
and because a few bad actors, and we see it every day in Becker's. Becker's is a great source of information on this, and almost every day it's another person arrested for a kickback or bad actor in play, and it is giving a bit of a tarnished sense to some of the ASCs coming out right now.
Yeah, in ASCs have proven over the test of time. The migration of total joints is a recent phenomena, but ASC's ownership by physicians have been around for many, many, many years. And they've proven their value. They are a lower cost, they are profitable, they provide good patient care. And so I don't think it's the model that is the issue. I think it's just there's some bad actors. Transparency is good. Everybody has to sort of, have their own barometer of ethical behavior. We are very big on disclosure. Every one of my patients knows all my conflicts of interest with device companies and with the implants that I use and with the ownerships that I have. And if a patient has an issue with that, then they'll go to the hospital. So that's that. And we never fight that. We never challenge that. We never, try to persuade them another way, because that'll be the patient where something goes wrong and then, things go bad. Yeah. I think we have really good laws. The anti-kickback laws are good. I think what's really helped keeping physicians honest is the whistleblower capabilities. Any person, any nurse, any scrub tech, any employee can be a whistleblower. And if they feel like there's an unethical behavior, then they can go to the government, say there's an unethical behavior here, and they can file a lawsuit, and then the government can participate in that lawsuit and then recoup Medicare dollars that have been spent there. And so, if you are a physician and you've got 20 eyeballs looking at you that you do ethical behavior, I think that really is sort of the police system that keeps us ethical.
So we touched on it earlier, the expenses that are influencing the cost of doing business in ASCs. And part of that is the talent. Everything from finding physicians down to administrative support. What are the dynamics that have been in play in the last few years? And how, if that rate of acceleration of pay, let's start with pay first, and then other expenses within the ASC occur, how do we mitigate, manage around that? Because you need people in the OR with you. You need people running administrative operations. You need pharmacy. You need rehab. Those are going up and up and up to match just cost of living.
Yeah, human capital is the most important thing for us, right? Because we need to have good nurses, we need to have good scrub techs, we got to have a good administrator. And the cost comes in multiple layers. The direct cost, them getting paid more. Then there's the cost of not being able to do surgeries because you don't have staff, right? You want to do a 7th or an 8th case, but you can't because you don't have the staff to do it. So that's a cost. And to me, the biggest cost is the turnover. I am fortunate in the situations where we have not had a single person leave our facility or get another job in the last 2 years. So we have the same nurses, the same scrub techs, which is very unique in the industry right now. I mean, in the hospital, I have a new person working with me almost every time that I operate there. So, I mean, it's like, I told a CEO once, how would you like it if your secretary was a new secretary every day? He dictates her a letter, and it's a different one every day. It'd be horrible, right? He would go crazy. And so that inefficiency created by that is probably the biggest cost from a dollar sign, but also from a quality sign. Just when I look around and I have a new nurse and there's sterile techniques or new scrub tech that is not used to the way I would like to have it done, I spend more time watching them, making sure they don't contaminate themselves, than me doing the operation. But my facility, I don't spend any time watching them because I know that they've done it perfect for the last 2 years. They're going to continue to do it perfect. So there are multiple issues there. And we need to solve that if we want to continue to do total joints in an outpatient setting, is the staffing issue. Because in the ASC, the current staffing agencies, they're not used to doing total joints. When we have somebody go on holiday, we go to a staffing agency, we bring in a person from a staffing agency. The other day I had a scrub tech that has ortho experience, never done a total joint. That's a nightmare, right? And so if we can solve that problem, we solve a huge problem in our industry.
Is that shifting occurring right now? Because I know during COVID, you had full-time nurses go to travel nurses, increase their salary from 60 to 100% in some cases. But I also know, in chatting with that cohort of people, that the quality of life also dropped dramatically. And the team members they played with dropped dramatically. Do you find that the mindset of the person who's going to come to an ASC and enjoy playing on an ASC team seems to be different than that in a hospital?
Very much so. At least in my situation, it's like this. We had actually one scrub tech that went to go travel and then came back. And the reason she went to go travel because her mom was very ill and she was dying, and so she took some travel, needed some time off, and then traveled and actually took an assignment in Chicago where her mom was. And then she couldn't wait to come back because in an ASC, you have a team approach, you have good culture, you don't have to take call. So for nurses to currently, I think their priorities are, they want to get paid fairly, they don't want to take call, because it's just very daunting. But more than anything else, they want to be on a winning team. And the hospital is, some hospital systems I think do a really good job, like Methodist in Houston, I think they treat their employees very well and they have a fairly low turnover and they also pay very well. But a lot of hospital systems really look at how many hours that they work, they flex them off if they don't need them, and so they don't get their hours and things like that. And so a lot of nurses are disgruntled, and part of that turnover, a little bit self-inflicted wound by the hospitals, just not creating that culture that they need in this high-stress environment, the operating room, because it is high stress and it is hard work.
Yeah, and the hospital setting is like any other big institution, right? It has its SOPs, it has its let's play down the middle. There's no intimacy in regards to the team members. And again, it's not just hospitals, any large organization. They have to have protocols outside of the classic healthcare protocols for patient safety. And that brings in impersonalization. Mm-hmm. And whether you're an incredibly hard, smart worker or not, you're going to get paid the same. Right. And so why try harder? Or why care about the person to your left or your right in a more intense way? Yeah. So it seems like that's a bit more the environment in a successful ASC.
Correct. So in the hospital, we call it the 3 o'clock shuffle because the new shift comes in at 3 o'clock. So if your patient's about to have surgery around 3 o'clock, nothing happens for an hour, and you're waiting for that patient to go back because the nurse doesn't want to go back because they want to go home. In an ASC, that's not the case. The nurses don't go home until we're done. And so in fact, our ASC, the nurses, they really like to go home. So that already improves efficiency because they want to get going, get done, and go home. And so I think it's a very healthy environment in the ASC while they work hard. And our nurses work extremely hard, and it's a stressful job, don't get me wrong. But I think the purpose and being part of a team and working together, efficiency and accomplishing something is important. And we do a lot of little things. You know, we go bowling with them, or we do a crawfish broil. Or the other thing is I always tell them unique stories of patients that are doing well. Remember Mrs. Jones that we did 3 months ago? Well, she just, climbed the mountain after her hip replacement. Because they don't see those patients back, right? I do. And so I think that little things like this make a huge difference. Mm. And probably the most important thing, every time I leave the operating room, I say thank you to everyone. Thank you goes a long ways.
Yeah. The interesting thing is there's this adage, old adage that says, hard work doesn't cause burnout. Hard work that you don't love what you do causes burnout. And I don't think people get burned out with really hard work if they enjoy what they're doing and who they're doing it with.
Yeah, I couldn't agree more. I mean, I'm more productive today than I've ever been before. This year we'll probably do 1,200 total joints. And the second busiest joint surgeon in Houston does about 700. And I am not anything close to burning out. And there's a huge number of physicians that have burnout. I mean, it's another Becker's article at least once a month or twice a month that talk about physician burnout. And I think it's not because of the work they do as a physician, it's all the stuff around it. When I walk into INOV8, I love my people. One of the nurses is a great golfer. I play golf with him. I'm not burned out because of the environment and the culture that I've created. And so I'm hoping that with what we've been able to create, we can replicate that, with help of people like you, and if we can solve the staffing problem issue that does exist in the ASC, in order to bring the joy back to physicians practicing medicine, because to me, it's the most rewarding thing that I've ever done, being a physician.
Do you think it requires an education at the ASC level for those that are either getting a counter intelligence talk track from hospitals, because hospitals don't want to lose their sort of staff to ASCs. And does the hospital staff or nursing or scrub, do they really have a good sampling of what happens in ASCs?
You know, they have outpatient departments, which are not ASCs, but are similar to ASCs. And nurses that work in the outpatient don't have to take call, I think, and they usually have sort of quick turnover and smaller cases. I think the hospital knows because they're losing nurses to the ASC. I think the support of the ASC comes from nurses talking to nurses. You know, you should come over here because it's a lot of fun. We have a really good team, and the vast majority of our nurses were recruited by our nurses. Whenever we go through an agency, we probably lose that nurse. But when nurses recruit other nurses, that's when you really got to figure it out.
Yeah, I think it's a big educational process.
Yeah.
So let's talk about final subject. So let's talk about running an ASC business, right? So you're a surgeon, doctor, and a businessman. And any of those by themselves is challenging.
Yeah, especially when you're dyslexic like me.
They always say, oh, most great performers, dyslexic or ADD, right?
Yeah, that's
right.
I've learned.
So, you know, to be any one of those three is a challenge. What is it like to run one of the most successful ASCs, and certainly the volume that you do and the outcomes, the fantastic outcomes you have? What's your guidance to the aspiring fellow who says, I want to do that? What don't they know?
I will give the advice, the most important thing is don't worry about money. You can't do what I do if you worry about how much money you make. It has to come from within intrinsic motivation, because it is hard. It is a full-time job and then some, because I have to take care of my patients. I have to do a good job as a surgeon, but then I also have to answer that text of this referral of an NFL player that needs to be seen tomorrow. And then I got to make sure that I catch my plane, that I go somewhere to, you know, design a new implant. It's a lot of work, and you're all over the place. And if you don't love it, you're not going to be successful with it. And the biggest challenge we've had with recruiting physicians is the first thing they ask, well, how do I get paid? And that's just the wrong question to ask if you want to be in the setting with the ASC. But again, I don't have burnout. I work very well, and I make a good income. But it's been extremely rewarding, and I will be able to extend my career because I'm in an environment that doesn't have burnout potential, nearly as high as if I were in a different environment. So that's what I would tell young, inspiring surgeons is go with the heart, don't go with the pocketbook.
And you're also incredibly active in developing technologies. Companies seek you out, both for implants as well as the surgical robotics side of the business. That's an area of excitement for people as well, who are coming out and freshly minted, and we get calls all the time is, how can I get aligned with a startup organization? How can I get time at the podium? How can I get exposure there? There's more to this. I love surgery, but I want to get involved in technology development. There's not one pathway forward, but what should people think about, and how do they get on that bus?
Yeah, as Dr. Renoir used to say, the 3 A's. I think you have to have ability, and availability. And the thing is, you just got to say yes. So if a device company asks you to do a study, you got to say yes. If the device company wants to do an evaluation of a new implant, because it's a progressive, stepwise career move that you do. You can't design a knee a year out of residency or fellowship. It's just not going to happen. No device company is going to ask you to design a knee if you've been in practice for a year. So you have to sort of prove your worth. Now, this stuff is not for everyone. You know, there are surgeons that are just not engineers, and they're not good thinkers of what is the next gig, and they shouldn't do that. But I would always encourage every orthopedic surgeon to at least have one other passion, and that could be being the key person in the practice to mentor the staffing and look at, team building activities. It could be, volunteering in church. It could be, being a wonderful parent and spending time with your kids. Don't be just a surgeon. Do something else that fulfills you as well. But to really answer your question is, you got to be in a system that can mentor you. So, I always have that conversation with surgeons that I interview to come into INOV8, that if they're interested in this, I will mentor them. I will give them access to the device companies that I would, but they have to prove themselves. So you really have to bring something to the table, because it's a very small portion of physicians that are innovators, early adopters, that have that capabilities of adding value to a device company.
And final shout out here by you, if you'd like. Are there any companies or technologies right now that you're especially excited about and are spending a lot more time than usual evaluating?
Yeah, I'm excited about the new acquisition of Conformis by a company that does 3D printing. And I just had my first call with the new CEO there, and he's going to come visit us at INOV8 to look at some of the stuff. And so I think, Conformis struggled for many years. They were burning cash. They weren't profitable. I think they have sort of reinvented themselves. And I'm glad that they're surviving, because they have tremendous technology, and it would have been really sad if they went away. And I'm glad it wasn't a big company that bought them, because they would have just put it on the shelf. And so I'm really excited about that. And then anything that is in the robotic world. We're working on a new robot that I think will have tremendous potential to improve accuracy in total joints. I think some of the telemedicine stuff is exciting. We do a lot of live broadcasts and televising, and I like the idea of opening up the OR to the general public. I do it with a little bit of trepidation, and I try to be really careful. And because some people take it to the extreme, and there's been some physicians that have lost their license. I think there was one plastic surgeon that was on TikTok doing live surgery, and the patient wasn't doing well, and she lost her license. So I don't want to be commercial in this. I want to be educational in this, because I think it's important for patients and the next generation of our doctors to kind of get a glimpse into the operating room to see what we do.
And we were down at INOV8, and our squad was down there, and you walked in here, and Marco right away showed you the boom over there, right, for your OR. So your OR is really amazing, because it's got its own studio within it. Yeah. I think you're probably one of the few surgeons in the world who do something like that. But again, you do it to educate.
Yeah.
Yeah.
And it's education of the general public. It's education of our future leaders, and staffing. I mean, if we talk about agency, creating an agency of the next generation of nurses that can help us in the ASC, that'd be a great educational process, so that they don't have to travel. So I think with COVID, the capabilities of an educational program has very much changed to make it virtual.
So you think that that's an opportunity of educating nurses in how to move in an ASC OR versus a classic OR by having broadcasting capability so they can watch the game go?
Absolutely. I think I hope that in the future we will have a certification for nurses to do total joints in the ASC, because it is different than doing a knee scope. And we have to come up with a very robust educational program, and that could be a big part of it. If you strategically place cameras and look at workflow and look at what needs to be done, because efficiency is so important for many reasons, not just the less the patients in the operating room, the less likely to have an infection. We got to get them out in 23 hours and 59 minutes. And so the less they're in the OR, the more time we have to get them ready to go home. From an efficiency standpoint, because the reimbursement is less, we want to turn these ORs as quickly as we can safely. So all that kind of stuff is important for nurses to know. And so I think a robust training program for our future nurses that do total joints in the ASC, I think will be necessary.
Well, I think you've got a large enough OR down there. We should chat about that.
Yeah, for sure.
Well, Stefan, my friend, thank you as always for coming over and spending time in 160 Studios.
It's been exciting. I've been wanting to come see this. This is amazing, and I kind of geek out on all this equipment. So thanks for inviting me. It's been fun. It's been a ton of fun.
Right. And you've got a session coming up. I want to make sure we pay some attention to that. Is it September or October?
It's September 28th through the 30th. It's the IMAC. It's the International Masters Anterior Hip Course. We've already had record re-enrollment from fellows and total joint surgeons. And it's really very specifically geared towards outpatient total joints and anterior approach hip replacement, which is kind of interesting because the anterior hip surgeons are the ones that started doing total joints in the ASC. So that's why we've combined the two, because we feel that there's definitely value to our faculty. We have an amazing faculty from all over the world. We have some of the leaders in the field from the Rothman Institute. Bill Maloney is going to be one of our speakers. He, for the first year Lifetime Achievement Award. We have some industry people there as well. You're going to come and help us host some of those things. It's very, very exciting. We're super happy that we were able to pull this off. We've done the course for 11 years before this first one, which was the identical course, just managed by a different company who unfortunately decided no longer to do it. So we took it under our own umbrella. My co-chairs, Joe Moskal and Ted Manson, are leaders in the field in many, many ways. And so we've been really excited about taking this under our own wing and us controlling all aspects of it. And so we're super excited.
And it's in person and virtual?
It's in person and virtual. The benefit of being in person is there's a 3-hour cadaver lab where we dig in cadavers and really sort of train surgeons on the nuances of anterior approach hip replacement, because as I shared with you in the past, anterior approach hip replacement is technically more difficult and is not what you get trained on generally as a resident or fellow, although now a lot of the fellowship offer that. When I trained, there was no such thing as anterior approach. There was one surgeon doing, that was Joe Amata in San Francisco, and it was really done in Europe. And so I had to sort of learn on my own. But now some of the surgeons that have been trained when I was trained that did not get the exposure as a fellow or resident, they come to these courses to really either get an initial exposure or get some fine-tuning of their techniques.
And this is going to be down in Houston?
Down in Houston, yeah.
And the dates again?
28th through the 30th of September, and it's in the Med Center. So we have the big learning facility, the Mighty, which is at Methodist Hospital in the Texas Medical Center, which is the largest learning facility, I think, in the U.S. And so that's where all the lecture, it'll be great.
Great, and we'll make sure our team puts all the contact info below here.
Sounds great. Awesome.
Okay. Stefan, my friend, thank you.
Thank you so much for having me.
I'm Joe Mullings from 160 Studios. Be well.